As As you know, in psychiatry, the entire field is essentially a diagnosis of exclusion. That is to say, we don't have specific biomarkers or brain scans to indicate when a condition is indeed psychiatric in nature. And you know that it's essential to take a systematic approach in order to make a psychiatric diagnosis. So I'm going to briefly review this stepwise approach to make sure that we're methodical, but I'm going to focus on step 3 for the purpose of this presentation. Step 1 is to always rule out malingering or a factitious disorder. You may recall that the primary indicator or the primary driver of a successful outcome in any psychiatric intervention is a therapeutic alliance. A therapeutic alliance essentially means that you have to trust each other, patient and provider, and that you are each acting in the best interest of the patient. Without that trust, no therapeutic outcome can arise. So to that end, we need to be sure that the person seeking care is truly seeking care for a problem they want solved and not for a secondary gain, which would be malingering, or that they're manifesting a physical symptom because there's some value, a sick role, and that would be factitious disorder, both of which are in the DSM, but the approach is different. The second thing that must be ruled out in any psychiatric diagnosis is that it's not a substance-induced condition, meaning it could be an illegal substance, a recreational substance, a prescribed substance, but it can also be the sudden cessation of that substance. And for that reason, a substance-induced disorder, which can cause a lot of psychiatric symptoms, should also be ruled out. The third thing that needs to be focused on and ruled out is the presentation of the symptom due to an underlying medical condition? And that's going to be the thrust of this presentation. And then I'll just briefly review the other 3 steps. Number 4, make sure that the symptoms that are being presented are not in accordance with a major life change. That is to say, are they having an adjustment disorder, or are they just having a normal reaction to an adverse life event? We don't want to pathologize normal reactions and feelings. Finally, you'll settle on a primary psychiatric disorder, and I will recommend that you say ADD for the end because a lot of the symptoms can overlap with a lot of other pressing concerns. So if you're having inattention, distractibility, irritability, while it can be ADD, it can also be generalized anxiety, major depression, bipolar disorder, etc. So you want to save the ADD diagnosis for the end. And then finally, you need to establish a barrier between no mental illness. So just because someone is oddly related or not acting according to the same frame of normalcy that you're familiar with, you don't want to necessarily pathologize. It needs to rise to the level of a disorder. And usually that means it's causing dysfunction in more than one area of life, be it social, recreational, professional, etc. So let's begin now with the neurological system. These are some conditions that can cause a psychiatric manifestation of symptoms. However, the underlying cause could be a cerebrovascular accident, encephalopathy, Prion disease, multiple sclerosis. And essentially, what you're going to do in order to determine if this investigation is warranted is you're going to be looking for localized impairment. Is there complaint of things like paresis or not moving, weakness or paralysis? Is there a difficulty in talking with aphasia or a sensory loss or a hemisensory loss? Are symptoms associated with a change in gait, in unsteady gait that's new? Is there a new change in a lack of coordination? These are things that may indicate that there may be a stroke, a tumor, or an infectious process. Those are localized impairments that should raise your index of suspicion in that your symptoms are not primarily psychiatric in nature. Non-focal symptoms such as dizziness, fatigue, altered mental status, seizure, headache, all very non-specific and categorized as a somatized disorder, but when they accompany psychiatric symptoms, should raise your index of suspicion to look further for an underlying neurological condition. Another condition I labeled here, prion disease, while rare, is manifested by cognitive symptoms, which are rapid decline in cognitive function, memory loss, confusion. Motor symptoms can occur, such as myoclonus, ataxia, extrapyramidal stiffness, tremors, visual problems, and less commonly seizures. And finally, some psychiatric symptoms. And as we get to the end of this, I'll tell you exactly how to distinguish it. Psychiatric symptoms can include acute agitation, aggression, a personality change, persistent sadness, anhedonia, anxiety, panic attacks. And the main development that should really drive your index of suspicion is by what speed of onset did the symptoms occur. And I'll repeat this throughout the presentation, but in general, psychiatric symptoms do not happen overnight. If you have something that is suddenly occurring, causing acute changes, your index of suspicion should be quite high in order to drive an investigation for an underlying medical illness. How do you do that investigation? Well, obviously, the most common thing is we have head imaging. MRI might show, say, some hyperintensity in the basal ganglia or some cortical ribboning. CT scan can also rule out other causes. Sometimes CSF tests may be indicated. In the outpatient setting, this is done through interventional radiology, but keep in mind, this person should not linger in the outpatient setting very long if they are having acute onset neurologic symptoms that should raise your index of suspicion. What are some other things that will raise your index of suspicion? Well, a detailed history should be obtained. What are you eating? Has it changed? Any supplements, new medications, travel, recreational activities, drugs and toxins, foodborne vectors? Are you a member of this newest group that had an outbreak due to lunch meat? The other side, of course, in the history is the onset of symptoms. How rapidly did the neurological and cognitive decline occur? Are there acute sensory and motor deficits? And of course, typical things present typically. So if the person is presenting with symptoms of mania for the first time in their 50s or 60s, the likelihood of that being a primary bipolar disorder or a manic episode, de novo, slim to none. One should have an index of suspicion for, did we have some sort of a toxic exposure, usually stimulants, but other things can cause it. So if there is an atypical psychiatric presentation, that should drive an index of suspicion to look for an underlying neurological or medical problem. Multiple sclerosis is another thing to think about. Often this will be accompanied by visual symptoms, which may be a manifestation of optic neuritis or diplopia, vision. There may be motor symptoms such as weakness, numbness, and spasticity, tremors. Sensory symptoms may also occur, manifesting in tingling, numbness, coordination and balance difficulties, new onset bowel or bladder dysfunction or incontinence, memory problems, inattentiveness and mood swings. Again, acute onset in nature or doesn't fit the typical presentation of a depressive or an anxious person. Risk factors for multiple sclerosis, obviously age occurs between 20 to 50, but that's also when most of the psychiatric conditions manifest themselves. It is more common in women and those with a family history. There is a higher prevalence further from the equator someone is, the northern regions, during childhood. So in your social history, where did you grow up? If you grew up in Maine compared to if you grew up in Florida, there may be a higher incidence. Mind you, that's epidemiological in nature and not diagnostic, but it's worth eliciting in order to inform and drive an index of suspicion. Chronically low vitamin D and previous infections with Epstein-Barr are some environmental factors that may drive this development of symptoms. And the neurological evaluation exam, obviously, You're looking for systemic signs, hyperreflexia, a Babinski, MRI might show some white matter lesion changes consistent with demyelination. A lumbar puncture might have oligoclonal bands in the CSF. There may be some evoked potentials and delayed response times indicate demyelination. So you might have a nerve conduction study as well. Clinical context pattern of this. So you're looking for, well, how long do the symptoms last? Are they all the time? Do they come and go? Is the person essentially telling you this is a relapsing and remitting course that's getting progressively worse? Are they in a plateau phase? I had these symptoms a few weeks ago. I don't have them now. I'm just worried what they may have been. Those are things to indicate some sort of underlying neurological condition. The other thing is multiple episodes affecting different body parts, lasting over 24 hours, separated by at least 1 month. And what you're doing is sometimes you need the tincture of time in order to clarify the diagnosis. Many psych diagnoses have to persist for some time, and the same is true for making an accurate neurological diagnosis. You essentially need to maintain this high index of suspicion for any neurological condition in which a patient presents atypically with symptoms, especially if it's accompanied by neurological signs and symptoms. Early recognition is going to be key to provide optimal care. So other underlying medical conditions that can cause psychiatric symptoms include things such as HIV-associated neurocognitive disorders, and this would have key psychiatric manifestations in the cognitive domain, that is to say memory, difficulty with attention and concentration, impaired executive function, slowed thinking and processing speed. Motor symptoms may manifest as well, and that would look like unsteady gait, coordination problems, tremors, muscle weakness. Again, what you're seeing here is a cluster of neurological symptoms that are accompanying psychiatric symptoms and behavioral symptoms, such as depression, anxiety, irritability, and mood swings. Raising the index of suspicion to clinical symptoms would be the progressive cognitive decline and difficulty in performing daily activities. Risk factors obviously include a diagnosis of HIV/AIDS, noncompliance with antiretroviral therapy or ineffective antiretroviral therapy. That may be seen on a low CD4 count and a high viral load, which is essentially unheard of in the current era, but it can happen, so you need to cast a wide net. Neuropsych testing can always be helpful to help clarify a diagnosis. Brain imaging, MRI or CT scan, and of course, blood tests. Syphilis, another infectious disease on the rise, which can manifest as latent syphilis with cognitive symptoms. And again, memory impairment, confusion, impaired judgment, and dementia-like in an atypical age range. So I don't expect to see somebody with dementia at age 50. So if that happens, you need to look. They may have signs and symptoms of depression and maybe mania, but rare. Psychotic symptoms, people don't suddenly become psychotic in their 40s or 30s or 60s. If someone's having audiovisual or olfactory hallucinations or delusional thinking or disorganized thoughts, those should all prompt investigation for an underlying medical condition, in this case, infectious disease. Someone with acute onset personality changes, irritability, apathy, social withdrawal, all of those are some indicators that there may be something more going on, especially if it's acute onset. Motor symptoms can be tremors and unsteady gaits, dysarthrias, difficulty in coordination. And when you do your broad review of systems, you can ask about skin conditions and chancres and rashes, any headaches or visual disturbance associated with what symptoms you're presenting with. High-risk sexual behavior, a history of men who have sex with men, and I say this rather than gay, because really it's not about the identity as much as it's about the behavior and the symptomatology that may follow. Diagnostic evaluation, obviously, serological, RPR and VDRL testing. Lumbar puncture may be necessary to get a clear diagnosis. And finally, Lyme's disease. Cognitive symptoms with that would include memory impairment, difficulty in inattention, slowing, impaired executive function, again, anxiety, depression, irritability. They're non-specific, but it's the constellation of symptoms and the acuity by which they arise that is increasing your index of suspicion for an underlying medical condition. Again, hallucinations and delusions are less common and should not randomly occur. So if you have them, look into it. Sleep disturbances are quite common in the general population, but we're looking to have sleep disturbance, either insomnia or hypersomnia, paired with this constellation of symptoms. In addition, you may notice some apathy, social withdrawal, personality changes, chronic fatigue, numbness and tingling, any neurological symptom that manifests, that's concrete with psychiatric symptoms should drive your index of suspicion to look for an underlying medical condition. Rashes, of course, tick bites, especially in endemic areas, the typical bullseye rash or systemic symptoms. Obviously, if they're having fever, chills, etc., now we're suddenly looking for underlying medical conditions. Test, of course, is the ELISA in the Western blot. MRI can be helpful, lumbar puncture, especially if you're looking for a manifestation of encephalitis. And there should always be this index of suspicion driving for infectious disease like HIV, syphilis, or Lyme's. And it could be maintained when patients present with atypical signs and symptoms. Early recognition should lead to a comprehensive evaluation. Let me just say a little bit here about HIV-associated neurocognitive disorder. So this is a prototypical example. It may be a 45-year-old male diagnosed with HIV 10 years ago on antiretrovirals with good adherence, no past psych history, and the partner reports, because the patient may not be aware, that this person is now struggling to recall conversations, frequently misplacing things. What you're hearing here is that atypical presentation of dementia-like symptoms in a very young age. Now, adherence, these medications now are so easily done. Many people are getting meds online, but they're not necessarily doing adequate follow-up, having routine testing. Men notoriously don't go to the doctor if they're not experiencing a functional decline. So this is where getting good collateral information may drive rather the index of suspicion to go ahead and image this person. What does the workup look like in someone with associated HIV neurocognitive deficit? Well, brain MRI, looking for diffuse cerebral atrophy and white matter changes. Lab testing, routine blood work, but we're looking at the CD4 and viral load to look at HIV progression. And then, of course, what is the role here? Well, yes, infectious disease is the primary treater in this instance, but you realize that this person now is going to have those secondary symptoms that may require psychosocial support. They may indeed become depressed, and it would not be reasonable to treat the depressive component, especially because depression is one of those triggers for reversible dementias or pseudo-dementias. Also, there will be anxiety as someone tends to undergo this new comprehensive evaluation, because until we know, we're basically trying to diagnose the unknown, and that could be anxiety provoking. Physical therapy is always helpful, even if it's to rebuild and regain. And it provides support, distraction, and structure to the day. It can be quite helpful in that respect as well. What might syphilis look like? Well, imagine if you hear of a 60-year-old female retired teacher who may have been diagnosed, say, 15 years ago, treated with penicillin, and no past psych history. That's key. No past psych history at 60 years old. And now suddenly we're having memory impairment. This could be mild cognitive impairment. It could be early onset dementia. But we're also having symptoms of depression, anxiety. That could be explained by life circumstances, impending retirement, lack of purpose, no social network. How about psychotic symptoms? Well, now if they're having psychotic symptoms with mood symptoms, that's already driving a high index of suspicion towards something more serious. The thought content should not be disorganized. And then we're having personality and behavioral changes marked by irritability, apathy, social withdrawal, and aggression. So those are some symptoms to keep in mind. What does the workup look like for neurosyphilis? Well, leptomeningeal enhancement may be seen on the MRI. This can be seen in contrast to MRI studies indicating inflammation. It doesn't give you the answer, and you'll still need to do the antibody test and cerebrospinal fluid test. They may also have symptoms of late infarct or inflammatory changes. They may have microstrokes, and that is essentially what the workup would look like. Now, in Lyme's disease, Lyme's disease may show you, say, a person who works in wilderness or works outside a lot. They will tell you typically if they're high risk of their previous exposures. They typically know the antibiotics they're on. This is not the same thing as what we'd say a chronic Lyme infection. That's a whole different world. This is purely somebody that has had Lyme's, believes it was sufficiently treated, but you know how people are with antibiotics, they typically don't finish them. But they're now presenting with these acute onset cognitive mood symptoms and psychotic symptoms. So if the history is there, it's worth doing the Lyme's test in Western blot to further clarify. Are we dealing with an active latent infection? So the Lyme workup would include the following: history of exposure, obviously, the ELISA test on the Western blot, neurological examination, plus or minus some head imaging, plus or minus some lumbar puncture. This can be seen by infectious disease or neurology. So if you're looking for a consult, that's where this is going to go. And then treatment typically involves, obviously, treating the active infection, doxy 100 milligrams twice daily for up to 21 days, and ceftriaxone for daily for 14 to 28 days. And then the supportive treatment is going to be around establishing a good sleep cycle, cognitive, dealing with cognitive symptoms, and if pain management is needed, that should be addressed as well. Psychiatric manifestations of rheumatological and autoimmune disorders. So systemic lupus erythematosus, if there was a nickel for every time someone wants to know, is it lupus? I mean, this even makes its way into pop culture. When the janitor on the house episode always offers, is it lupus? And then it's not lupus, but it could be lupus, and we need to look. So the way we look is first we're going to assess symptoms, because that's what we do in psychiatry. Memory deficits, difficulty concentrating, cognitive slowing, executive impairment, mood disorder, depression, anxiety, and bipolar-like symptoms. Psychotic symptoms may also be manifested. Also behavioral changes such as irritability, apathy, and personality changes, as well as sleep disturbance, headache, confusional states. These are the things that will raise the index of suspicion. But in addition, when we're thinking autoimmune, constitutional symptoms such as fatigue and fever, weight loss, muscle and joint pain, rash, photosensitivity, organ involvement. Also, when you do that routine urine for a toxicology screen, a UA would be helpful. If you notice proteinuria or hematuria, it's worth an investigation. If they have cardiopulmonary symptoms, then you may investigate that as well also. Those could be driving the fatigue and the apathy and the listlessness. More commonly, rheumatoid and autoimmune conditions occur in women, typically diagnosed between the ages of 15 and 45. There is a higher prevalence in African American and Hispanic and Asian populations. Also, if there's a family history, so when you're doing your 5P formulation, one of the things that you may want to capture is there a predisposing biological factor determinant, that is to say, mom and dad? Is there a history of autoimmune? That would be a biological predisposing factor. In the blood workup, there is a positive anti-DNA, anti-double-stranded DNA. So those, and in addition to decreased complement levels, C3 and C4, with the positive findings, MRI of the brain and a lumbar puncture in EEG. We're doing all of this for completeness. Now, this is done in a variety of ways, but the other major take-home message is this is a multidisciplinary approach. And what your role in psychiatry is going to be is to articulate what it is that you're seeing from a psychiatric perspective that is atypical, that is driving your index of suspicion to make the following referrals, consults. It's not to say that this will fall on the psychiatry to do this investigation. Sarcoidosis is another symptom that condition that can cause psychiatric manifestations due to this underlying medical condition. Again, memory impairment, inattention, difficulty concentrating, generally depression, anxiety, irritability, hallucinations, and delusions. The same symptoms of apathy, withdrawal, personality changes. The acute onset in nature is the driver here. Headache, seizure, and fatigue. Those are other things that may warrant further investigation. If your patient is complaining of symptoms that are neurological in nature, in addition to the behavioral and emotional symptoms, that is driving the index of suspicion. Further raising it would be persistent dry cough, shortness of breath. So it's important to do a good medical review of systems, not just psychiatric. That's why they're seeing you. Cranial nerve palsies, peripheral neuropathy, meningitis-like symptoms. All of these are more common. Sarcoidosis is more common in adults 20 to 40 years old, higher in prevalence in African Americans and Scandinavian populations, slightly more common in women. Family history of sarcoidosis or other autoimmune also drive this. A blood test, elevated ACE level, hypercalcemia, positive findings on a chest X-ray or CT scan, and the brain and show high lymphadenopathy on those chest scans. Not seeding granulomas, late granulomas is findings, and they also describe things like round flax appearance. Those are phrases you may see on radiologic tests. Finally, vasculitis. There are key psychiatric manifestations here. Obviously, the mood, anxiety, irritability, rinse and repeat. Cognitive symptoms include confusion, memory, or impairment symptoms. The psychotic symptoms would be the hallucinations, delusions, disorganized thinking, behaviorally apathetic or have an acute personality change. And it looks like a stroke-like symptom, but there is no bleed and there is no clot, and it's more than 24 hours, so this might make you think of vasculitis. Peripheral neuropathy may manifest. There may be some constitutional symptoms such as fever, weight loss, fatigue, palpable purpura. Skin ulcerations may be noticeable as well. There may be some secondary organ involvement, hematuria, proteinuria, shortness of breath, gastrointestinal symptoms, abdominal pain. And the risk factors are variable in age and onset and gender prevalence, but a personal history of autoimmune disease or a recent infection which can trigger the vasculitis symptoms to manifest can also be considered. What would you see? Non-specific elevated inflammatory markers of ESR and CRP, autoantibodies, ANCA and anti-double-stranded DNA, MRI and CT scan of the brain, angiography. You're looking for inflammation of the vessels, MRA or CTA, and then eventually the definitive diagnosis is made by a vascular biopsy to look for inflammatory markers directly at the tissue site. Again, the driving notion here is there should be a high index of suspicion when a patient presents with atypical psychiatric symptoms and comorbid physical symptoms, neurological symptoms, abdominal, cardiopulmonary, or incidental noticing of, say, protein in the urine or hematuria. Those should be driving the investigation. So what might an SLE patient look like? Maybe typically a 28-year-old African-American female who presents with a constellation of psychiatric symptoms, specifically complaints of memory deficits and difficulty concentrating, cognitive slowing over the past 6 months, experiencing severe episodes of depression and anxiety, punctuated by periods of intense irritability and disorganized thinking. This is not the typical presentation of someone with depression, anxiety, or even dementia. So this is why you would want to pursue an investigation of an underlying medical condition. Look at the age, look at the constellation of symptoms. That's not usually how depression, dementia, or anxiety present. It's too young, too many symptoms, hallucinations are not common. The drug use, right? Because you've done the first 2 steps. So what does the SLE workup look like? Well, it's going to be findings of low C3 and C4, specificity of low specificity. Those are not like, aha, that's it. It's just things to support the diagnosis. They can also occur in various autoimmune conditions. Moderate sensitivity, such as low complement levels, are often seen in SLE. Positive ANA findings, low specificity can be positive in other autoimmune diseases. So it's not so much ANA is up, therefore it's SLE. No. This is where it's helpful to have rheumatology consults and to have a conversation to say, what can I do or what should I test on the way to the referral to you? Anti-double-stranded DNA, it's a positive result. It has high specificity for lupus, especially if there are high titers. And the sensitivity is moderate, about 70%, which indicates active disease, particularly in lupus nephritis, which is where you might see the hematuria and proteinuria. And then the anti-Smith antibody test, this would be positive in somebody with lupus, has a high specificity for lupus, low sensitivity, but high specificity. So you don't want to do this as a screening test. These are not cheap. And then finally, MRI of the brain, they show white matter lesions, infarcts, or other abnormalities consistent with a neuropsychiatric SLE presentation. Lumbar puncture can also be done. Findings, they show the presence of oligoclonal bands and elevated protein levels, or something called pleocytosis. This is quite specific, but they can also occur in other inflammatory conditions. EEG may show diffuse focal abnormalities consistent with neuropsychiatric SLE. It's non-specific and it's low sensitive, but you're basically looking for things to support. There's more going on here than a psychiatric syndrome. There is likely an underlying problem. In neurosarcoidosis, person may look like a 35-year-old African-American female who presents with a range of psychiatric symptoms, including memory impairment, difficulty with attention, cognitive slowing over the past 4 months. She may have experienced episodes of severe depression and anxiety, along with irritability, social withdrawal, and they may also report auditory hallucinations. Notice here that the cognitive symptoms of the memory impairment disorder, the psychotic symptoms, are not specific to any one condition, but these are a constellation of symptoms, especially when combined with things like headache, seizure, fatigue, paresthesias, that will say time to investigate more. Neurosarcoidosis workup, the patient is an adult with the typical age range. You may find an elevated ACE level. These are not specific for sarcoidosis, but it is elevated in 60% of patients with pulmonary sarcoidosis. You may also see hypercalcemia, but that can also occur in other instances in which cells are breaking. Sensitivity is moderate for sarcoidosis, especially when combined with other criteria. When you do the chest X-ray or CT scan, you may notice bilateral hilar lymphadenopathy, and that's highly specific for sarcoidosis when combined with diagnostic criteria. What might be the incidental reason you see that? Well, if they had a positive PPD and they're being admitted, you may have done a chest X-ray and you see this incidental hilar lymphadenopathy. That's typically how that manifests, unless we're just specifically pursuing it. Imaging of the brain is non-specific. And then, of course, if there's a lymph node that's present, biopsy is the definitive means of diagnosing the lymph node. There may be some ophthalmic changes. So ophthalmology may weigh in this uveitis, this inflammation of the iris. And it's moderate specificity because uveitis can occur with a host of other conditions. But when you have this constellation of symptoms and findings, that's what's driving the diagnosis of an underlying condition. It's like many unrelated things with concrete findings. That tends to be what lands people into a This is a psychiatric manifestation here of vasculitis. The patient is a 45-year-old male who presents with significant psych symptoms. Again, you'll notice depression, anxiety, irritability over a short period of short term. also reporting confusion, memory impairment, difficulty concentrating, with hallucinations and disorganized thinking. The definitive diagnosis for vasculitis is going to be biopsy of the vessel. So blood tests in order to maintain this high index of suspicion and to cause early recognition. We're going to see an elevated SED rate, elevated CRP. We'll have some positive ANCA findings. Again, all of these are inflammatory markers, but at the end of the day, it's the biopsy of a lesion or a vessel that will give you, or the kidneys, which will give you the definitive answer if this is indeed vasculitis in nature. How do you know where to biopsy? You're going to go where you're finding downstream effects. So, for example, if you find the hematuria proteinuria, then you're going to ultrasound the kidneys, and then, depending on renal involvement, then a biopsy may be done. If you're having a lot of head symptoms and the like, pain symptoms, head imaging, that will determine where best the biopsy would be. Now, what about psychiatric manifestations with underlying endocrine disorders? Now, hypo and hyperthyroid tend to be the most common things that people like to look for, so much so that in the general medical workup, TSH and free T4 are routinely worked. And that's not a bad thing to do. Some cognitive symptoms they may have include memory, difficulty with attention. Depression is more common in hypothyroid, some symptoms. Psychotic symptoms are quite rare, except if they have mixed edema. And so then that would be obviously a more further along course of illness with thyroid disease. There would be some behavioral changes, slowed speech, movement, decreased libido. Hypersomnia is not completely abnormal in hypothyroid, as well as persistent weight gain, cold intolerance, and the usual dry skin, constipation, hair loss, bradycardia. All of that should definitely drive an index of suspicion. Hyperthyroid symptoms may include memory impairment and inattention, agitation, and psychosis can occur with thyrotoxicosis. Pay attention to if this is acutely occurring in the onset of post-thyroidectomy. This can be a rapid onset situation. Obviously, they may call psych, but it's not psych in nature. And then behavioral changes such as restlessness and decreased libido. Physical symptoms with hyperthyroid include weight loss, heat intolerance, sweating, diarrhea, hair thinning, tachycardia. All of these are things that raise your index of suspicion when someone has atypical psychiatric presentations marked by a sudden onset or worsening, or refractory symptoms. Multiple things are co-occurring and they're just not responding to your usual treatment. Getting a good family history of thyroid disease, or personal history of thyroid disease, TSH and free T4. I would not use thyroid antibodies because this is elevated in a certain portion of the population without any problems, but it helps support the index of suspicion if that's where you're going. Cushing syndrome is another situation in which you may notice depression, anxiety, and irritability with memory impairment and inattention, with comorbid hallucinations, delusions, and disorganized thinking. There may also be fatigue and decreased libido and a sleep disturbance. You may also notice manic symptoms because this is a condition in which there's too much steroid. So think about the symptoms you notice if someone who's on, say, high-dose steroid. You may see these symptoms occurring. They will also have the classic features of central adiposity, moon face, and the buffalo hump, with the thinning skin changes and some bruising. So this is why a biological review of systems is also important. You also want to inquire about menstrual irregularities and intolerances to glucose. Is there a randomly high glucose level, more than you'd expect? Atypical psychiatric presentations, again, I'll repeat, are refractory symptoms with multiple co-occurring symptoms with the classic picture of the central adiposity, buffalo hump, and thin skin. The diagnostic evaluation involves a 24-hour urine for free cortisol, maybe even a late-night salivary cortisol test. What determines all of this, of course, is where the person is located and how feasibly can these tests be done. Sometimes patients may get admitted for the purpose of testing. The opposite of Cushing's, of course, would be adrenal disease or adrenal insufficiency. This would be more marked by anxiety, irritability, not so much depression, although that can also occur. Impairment and inattention, fatigue, and decreased libido. This can happen if someone suddenly goes off steroids as well, that they're supposed to be on for another condition, perhaps an autoimmune or asthma. Someone on prolonged steroids who suddenly goes off may have insufficiency with a lot of symptoms that may come to your attention. The most dangerous ones, of course, if someone's hypotensive, has severe electrolyte imbalance, hyponatremia. This then again leaves the domain of psychiatry, puts them in the acute care world. So all of these symptoms should be known. Serum cortisol level and ACTH stimulation test is done. Electrolyte panel, imaging study, CT, MRI of the adrenal gland if we're looking for a primary adrenal insufficiency. So that high index of suspicion is important as well. So look at this chart here. This is just a grid to keep in mind to look at neuropsychiatric symptoms associated with with psychiatric manifestations. And here you are showing the different domains of cognitive symptoms, mood disorders, psychotic symptoms for the various endocrine disturbances. Of course, there are metabolic symptoms that may develop due to nutritional deficiencies such as thiamine B1, which we get with maybe alcohol use disorder, Wernicke's encephalopathy, Korsakoff syndrome, manifesting by memory impairment and confabulation. B12 deficiency typically comes with paresthesias, numbness, tingling. B3 deficiencies, rare, but you can notice anxiety, depression, not quite responsive to therapy. Vitamin D is implicated across the board, as can iron, which can cause depression symptoms and fatigue and listlessness. Zinc deficiency, magnesium deficiency. These all are atypical presentations with refractory symptoms as to what would drive your index of suspicion. And of course, the treatment is to supplement the missing nutrients. Neoplastic conditions, these are worth considering, especially if you're working in psycho-oncology. But key psych manifestations can include mood disorder, anxiety, irritability, memory impairment, confusion, inattention, cognitive slowing, hallucinations, paranoia, delusions, personality change, aggression, social withdrawal, insomnia, seizures, ataxia, myoclonus. Again, general neurological symptoms co-occurring should be investigated. So what's the diagnostic workup? What do you do in general from psychiatric perspective? You're going to work up to rule out underlying medical conditions that have raised your index of suspicion when evaluating psychiatric symptoms that are presenting in an atypical fashion. Rapid onset development of psychiatric symptoms such as confusion, memory impairment, mood disturbance, psychosis, without a clear psychological trigger. Fluctuating symptoms also should trigger this index of suspicion. Episodic psychiatric symptoms that wax and wane, often without a clear pattern. Refractory symptoms, psych symptoms that do not respond to standard treatment. Or multiple co-occurring symptoms, that is to say, presence of both cognitive and mood symptoms along with neurological signs and symptoms. These are things that should trigger the investigation. Also, constitutional symptoms and specific liver involvement that may show up incidentally on their routine tests. And you'll take a detailed history to focus on family as well as biological predisposing factors, which may also be the perpetuating factors to why the problem has not resolved itself by the time they're seeing you. Imaging studies should be guided by symptoms rather than blanket imaging. So in conclusion, preventing over-testing and fruitless investigations in psychiatric evaluation requires a balance of thoroughness with the need to avoid these unnecessary tests. So a strategic approach, a systematic approach should be employed. A detailed psychiatric history to explore onset, duration, progression of symptoms, including family psychiatric history, medical history, review of chronic conditions and past surgeries, significant illnesses, medication history specifically, include all the current and past meds they've been on for the herbal supplements. What were you trying to treat with that supplement? What were you trying to prevent with that supplement? May give some insight as to their history that may jog their memory. Substance use or sudden cessation to look for withdrawal symptoms as well as oxydrome should also be considered. And then a targeted physical exam that follows the symptom that they're presenting. Judicious use of diagnostic tests is warranted, and reserve the extensive testing for cases where initial findings suggest possible underlying conditions, but of course you'll have to collaborate with the key subspecialist to prudently select and manage the patient. You want to develop an algorithm or a decision tree that guides how to pursue further testing in a multidisciplinary manner. And of course, consider referral to specialists that will provide the necessary close monitoring. And along the way, you want to educate the patient and build that therapeutic alliance and help them understand the rationale for or against certain tests, because you will have people that come in demanding every test, and incidental findings are not harmless. They generate a lot of anxiety. Selective testing should be focused on red flags such as sudden onset symptoms, refractory symptoms, neurological symptoms, and then also literature review to stay up to date on the latest research guidelines at the intersection of medical conditions with psychiatric symptoms. And you want to use key screening tools and really articulate your findings so that you can build the case for your consultant. Yeah. I hope you found this helpful. If you